When a doctor puts their signature on a prescription, what are they actually signing off on? It seems so quick, maybe just a minute in a consultation. But that signature it's really the final step in this huge, legally binding risk assessment.
It absolutely is. Prescribing is the ultimate high-stakes decision.
It's where clinical judgment meets patient safety and legal responsibility all in one go.
Exactly. And you shared the latest guidance from the UK's General Medical Council, the GMC, on good practice in prescribing. It's a really critical document.
So our mission today is to sort of give a shortcut to being well-informed. We want to strip away all the compliance language and get to the core expectations.
Yeah.
And look at how modern practice, especially remote care, changes the rules.
And we really need to understand the tension in the heart of it, that tension between the individual doctor's accountability and the compliance of the whole system.
So this framework, it applies to everyone.
Every single doctor. Face-to-face clinic, advising on something over the counter, using a fancy electronic system, it covers it all. And it's constantly updated, like the big changes in 2022.
Okay, let's unpack this. If accountability is the main theme, where do we start? What is the single non-negotiable starting point for any prescription?
It's all about clinical justification. A doctor can only prescribe when they have, well, adequate knowledge of the patient's current health, their diagnosis.
And they're sure the treatment will help.
More than that, they have to be genuinely satisfied it will meet the patient's specific needs. It's not enough to think it might help. You have to be able to justify that decision.
That immediately makes me think about team prescribing. I'm a hospital doctor, and their specialist suggests a prescription, and I sign it. Does the responsibility shift at all?
No, and that's absolutely crucial. Accountability sits squarely with the person who signs.
The signatory.
The signatory. If you, the doctor, sign that paper or you authorize that electronic request, you are the one who is ultimately responsible for making sure it's appropriate, necessary, and safe.
Even if a colleague proposed it?
Even then. You're
Yeah.
signing off on the risk. You can't just trust the system or the colleague implicitly.
Which means I have to be knowledgeable. So what resources does the GMC say are, mandatory for keeping up that knowledge?
They expect continuous learning in pharmacology, in therapeutics, and, this is a big one now, in the technology you're using.
Right.
And they're very explicit about using safety resources. You mentioned the BNF, the British National Formulary. That's not just some reference book on a shelf.
Yeah.
It's the authoritative guide. Using the BNF, using NICE guidelines, MHRA alerts, that isn't optional. It's a fundamental part of showing your decision was justified and safe.
Okay, here's where the context really matters. The guidance is clear that the type of consultation, remote versus face-to-face, has to be suitable. When does the GMC say, stop? You absolutely cannot prescribe this without a physical, in-person assessment.
There is a very hard stop. One specific category of high-risk treatment,
Which is?
non-surgical cosmetic injectables. We're talking about medications based on botulinum toxin, so brands like Botox, Dysport, Vistabel.
Ah.
The rule is firm.
Oh.
A physical examination must be carried out before you prescribe them. They must not, under any circumstances, be prescribed remotely. It's a very clear safety barrier.
That's a really important, memorable rule, and it reflects some of the professional tension in that area of practice, doesn't it?
It does.
So beyond those injectables, what other factors should make a doctor think twice and say, I need to see you in person?
Any situation where the context is, well, unclear or potentially vulnerable.
For example?
So if you suspect the patient might lack the capacity to consent, or if they seem to be under pressure from someone else, which could be a sign of coercion or even abuse, that uncertainty almost always mandates a face-to-face meeting.
You're trying to verify the reality of the situation.
Exactly. Before you initiate a potentially high-risk treatment.
Now let's talk about the immediate personal danger zone. Prescribing for yourself or for people you're close to.
The standard here is very simple. Avoid it. Avoid it wherever possible.
Why?
Because your professional distance is gone, bias just creeps in, you can't be objective.
And what about for controlled drugs? Is there any wiggle room there at all?
This is a near total prohibition. Controlled drugs must never be prescribed for yourself or for close relations. There's just one extremely narrow exception.
An emergency.
A documented genuine emergency. And that means no other prescriber is available without causing an unsafe delay, and the medication is needed right now to stop serious harm.
And you'd have to document that incredibly carefully.
Immediately and comprehensively, you have to explain exactly why you had to break that rule.
Right. So let's move to the other high-risk categories. Controlled drugs, or CDs, and using medicines off-label. What extra checks are needed for the normal prescribing of CDs?
More risk means more safeguards. It's that simple. With things like opioids, gabapentin, sedatives, the risks of addiction and abuse are well known.
So you need more system checks.
Exactly. And if you're doing this remotely, you have to have really robust safeguards, excellent identity checks, and crucially, you have to verify the patient's consent to contact their usual prescriber, like their GP.
So you're closing the information loop, stopping people from doctor shopping.
That's the idea. And if you do have an emergency where you have to prescribe without the full medical records, maybe a patient lost their medication while traveling,
Yeah.
the GMC says it has to be a limited quantity and dose, just enough to bridge the gap until they can see a professional who has their full records. You're managing immediate risk, not restarting long-term treatment.
What about unlicensed use? Prescribing something off-label or a drug not licensed in the UK. Why would a safe doctor even do that?
It happens more than you'd think, especially in specialized areas like pediatrics, where a lot of drug formulations are only licensed for adults.
I see.
So you should only do it after a thorough assessment shows it's necessary to meet that patient's specific needs. Maybe there's no licensed alternative that's appropriate.
What's the extra professional burden the doctor takes on?
You have to be satisfied there's sufficient evidence of safety and efficacy for that particular use. And crucially, you, the doctor, are taking full responsibility for overseeing the patient's care and monitoring the outcome.
Because the manufacturer's license no longer guarantees that use.
Precisely. The liability shifts to you.
And how do you communicate that to the patient? It sounds complicated.
The patient must be informed, unless it's just considered routine practice in that field, or if you judge that telling them is likely to cause significant distress.
But what if they ask directly?
Well then autonomy is paramount. If the patient or their carer asks a question, you must always answer fully and honestly. Honesty trumps any concern about causing distress in that moment.
So really, all these rules come down to effective dialogue, consent, and transferring information. What does a doctor absolutely have to include in their patient history before they prescribe?
The GMC requires a two-way dialogue. You have to take an adequate history that specifically includes asking about everything outside the normal clinical stuff.
You mean like verbal remedies?
Verbal remedies, non-prescription drugs, illegal drugs, anything bought online. If you don't ask about it, you can't possibly predict a dangerous interaction.
And for consent, a verbal yes is usually okay. But you have to be sure the patient really understood.
Correct. The focus is on understanding. The patient needs to be able to grasp the likely benefits, the risks, the serious side effects, how long they'll be on it, and what monitoring is needed.
This brings us to what feels like the most difficult conflict. What happens when a patient refuses to consent to you sharing information with their GP?
This is the critical intersection of autonomy and safety. It's a real test.
So the patient refuses, and the doctor thinks this creates a significant risk.
Right. Maybe a risk of a bad drug interaction or someone else prescribing it inappropriately. The doctor has to explain those risks very clearly. And the guidance says if that risk can't be dealt with, the doctor must be prepared to refuse to prescribe.
Wow. So the duty to do no harm can actually force you to stop the treatment entirely.
Absolutely. Patient safety is the overriding duty. It can mean walking away from the prescription.
And that same principle applies to shared care, I assume?
Yes. Any shared care arrangement between, say, a specialist and a GP has to be based on clear agreement and communication. And it has to be in the patient's best interests, not just for convenience or to save money.
What if a doctor delegates the initial assessment of a patient to someone else who's competent? Where does that final accountability sit?
Right back with the person who signs?
Always.
Always. The doctor who signs the final script is responsible. Delegation doesn't transfer liability for the final professional act.
Okay, so prescribing is a system, not just one act. What about managing repeat prescriptions and learning from mistakes?
For repeats, the systems have to be secure, and they need regular critical review, especially after a patient comes out of hospital. Doctors need to be on the lookout for adherence issues.
Like someone asking for refills too early or too late?
Exactly. Those are red flags for misuse, or maybe that the patient isn't taking it properly.
And when errors or adverse events happen, what's the mandatory reporting system?
You have a duty to protect patients from harm, even if it's caused by a colleague. You have to question things you think are unsafe. But for national monitoring, the guidance is explicit. You must use the yellow card scheme.
The yellow card scheme. Who should be using that and for what?
Every doctor. You must use it to report any serious suspected adverse reaction to any medicine.
Okay.
And you also have to report any suspected adverse reaction, serious or not, to products marked with that little black triangle symbol.
What does that black triangle mean?
It means the drug or vaccine is new and it's under additional monitoring. It's a signal to doctors that reporting is absolutely vital because the full safety profile is still being built.
And just before we wrap up, let's touch on that detail about ethics in competitive sports. It's often in the news.
The professional standard is crystal clear. You do not prescribe medicines with the intention of improperly enhancing athletic performance.
It's a hard line.
It's a clean line between medicine and cheating. Prescribing must only be for protecting health or genuinely improving a medical condition.
Okay, so if we had to summarize the whole GMC perspective on prescribing safety today, what would the 3 key takeaways be?
I'd say first, the doctor who signs the prescription is always individually accountable. Doesn't matter who suggested it or how the consultation happened, you sign it, you own it.
No passing the buck.
None. Second, the high-risk areas, cosmetic injectables, controlled drugs, they trigger specific, non-negotiable safeguards. That might mean a mandatory face-to-face meeting or robust information sharing.
And the third?
Third, effective dialogue and transferring information to the patient's GP after you've provided care is essential. It's not a nice-to-have. It's how you avoid inappropriate repeat prescriptions and dangerous interactions.
So the GMC really forces you to grapple with this profound ethical conflict. If a patient uses their autonomy to refuse consent for you to share information, and that creates a real risk of harm, the standards demand you prioritize your professional duty to do no harm. So how do you, as the clinician, navigate that moment? That moment where you have to choose between respecting a patient's secret and refusing to provide a treatment you believe is unsafe because of that secret.
And that right there is the pattern of professionalism. The safest path often requires the greatest professional resolve, even when it feels incredibly difficult.
Internalize those high-tension decision points. They really do define the safest doctor in modern practice.